One of the key criticisms of the research in this area has been the real reliance on retrospective data. So AI can detect breast cancer at a rate that's similar to a radiologist. AI is a great idea in theory and great in research. Data is a powerful motivator, and it's definitely something that to protect.
All right. Hello, everyone, and welcome back to another episode of OncoDaily. And today I'm very, 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 very excited. I have a special guest, and we're going to talk about a special topic that's been on the news recently, AI. But we're going to talk about AI for patients and the patient sides. And we're not talking about like all patients. We're talking about specific patient population that has been suffering through breast cancer. I'm so excited today. I have a special guest with me, the VP of Education at Susan G. Komen. Krissa, welcome.
Hi, Roupen. So great to be here today.
It's great to have you. I'm very, very excited to have you here today. And especially like when we talk about the AI and the recent changes. And before starting recording, we are talking about the changes that's been happening in the field. It's just like mind blowing. It's changing every single day.
Pretty much. And the thing that's been most interesting to me is mainstream media picks this up and they talk about it all the time. So I'm excited to delve into a little bit of the complexity around the situation because we want to make sure that people understand what it actually means.
Yes, I completely agree. Before going that route, I want to learn more about you. Can you give me a bit of background, like what led you today to be the VP of Education, your current role at Susan G. Komen?
Yeah, of course, like everyone, I've had quite the journey in my life and never end up where you expect to be. But I'm a breast cancer scientist by training. I did my PhD in looking at blood vessels and breast cancer and especially how the immune cells support those blood vessels to lead to metastatic growth in breast cancer. But I came to Komen about 13 years ago, and I spent many years running our research grant process at Komen. But I really wanted to be closer to patients. So my job now as VP of Education helps me. I get the chance to translate this rapidly changing field. And my passion is really to help patients navigate this incredible amount of information that's out there. Um, Not just to understand it, but to be able to act on it and feel confident. Komen right now acts as that breast cancer authority for over 2.5 million people and growing. And why patients? Why did I want to go this route? It's really personal to me. I have a family history of a genetic mutation that significantly increases the risk of breast cancer. Mutation in P53, it's a bad one. And I know what it's like to have to understand and act on a lot of this confusing and frightening information. So our goal is really to help people navigate it and do it in a way that they feel confident to make those decisions with their healthcare team. There's been so many incredible advances in cancer care in the last decade. For those benefits to really impact people, they need access, and they need to be willing to be a part of it. There've been some great examples and some horrible examples in the past few years. So, really excited to talk more about that.
Oh, thank you for sharing that also um, point or idea about like your background, what led you to that. And I find so from my experience and talking to many, many people in the field, I find those people who made the biggest difference are the people who already either had a personal experience or had family member or had some predisposition to this and they really want to help people because like they are very, very motivated. And thank you for sharing that with us today.
Yeah, we often talk about how this is a difficult space to work in. We
Yeah.
lose people. It's research isn't quick. It's a slow process. You have to be really committed. So I'm really grateful for our community and for all of the incredibly um, smart people who are working on this because, like I said, we've made some incredible progress.
Yeah. Yeah. I want to shed light today. I think one of the things I want to talk about is like AI in breast cancer from patient perspective. And since you work with lots of patients and you are part of that patient advocacy group, um, can you tell me like right now how patients are using AI when it comes to breast cancer patients? Like, or are they using AI and how are they using AI?
Um, so from a breast cancer perspective, there's a lot going on with AI. Like I said, you see it in the news. And there's some really incredible research coming out, but it's fairly complex. So the area with the most evidence to support it right now is the detection of breast cancer through the application of AI to screening mammography. So you go in, you get your screening mammography, and the radiologist reads the images and looks for suspicious areas. Well, they can also run it through AI, which has been shown to do as well or better than a radiologist. Some countries require a second radiologist to read the films because it's a little bit of an art as much as a science because
Mhm.
it's not easy. Um, and so the idea is that you're going to see more of those cancers, catch them early, and be able to treat them better. Um, One of the key criticisms of the research in this area has been the real reliance on retrospective data. So looking back and
Yeah.
saying, "Oh, here's an old mammogram, and this person got cancer. How do
Mhm.
we how did that work?" Um, but in the last year or so, we're really seeing these prospective studies where people had AI reading and then they looked forward to see what happened to them that are confirming those benefits in supporting mammography screening with AI. Um, so I 100% this is technology that's going to get there. Implementation is going to have some challenges to overcome and how that really looks like and actually getting it to patients. But the consensus is right now that AI can detect breast cancer at a rate that's similar to a radiologist, and it can reduce the burden of work, so make it people more efficient, which is always great. We like to be more efficient. Um, the Messiah trial that came out this past year, the breast cancer detection rate was about 20% higher than that standard double reading, which was really great. One of the downsides was it did detect more of the ductal carcinoma in situ, so those really early stage breast cancers. So then that we worry that maybe we're catching things that won't turn into cancers, perhaps.
Mhm.
So um, it's a debate about overdiagnosis. Are we treating people who maybe don't need treatment? I don't know. We're not there yet. That's why we need more of those prospective studies looking forward. Um, there are other uses of AI in breast cancer. These aren't what patients are really seeing as much because they're still really in that earlier stage of research.
Mhm.
Um, AI is available in many imaging clinics right now. If you go to get a mammography, you might be offered it, which is why I think it's really hit the news a little bit more because people don't know what it is and why it would help them. So AI systems, they can also look at one of the ones that I think is most interesting is the ability of it to predict a metastatic disease, right? Because that's where we really want to lose people to metastasis in breast cancer. And so that's a really key. And the earlier we can catch that and keep it under control, the longer and better quality of life these
Yeah.
patients. So excited about the work that's happening there. Um, there are also AI-powered tools looking to help get to an accurate diagnosis. So not just looking at screening where you're like, hey, is there something suspicious there? But really getting to what type of breast cancer it is. Is it going to be more invasive? And then, towards metastasis. At Susan G. Komen, we're big into personalized treatment, and AI really has an opportunity there because it's taking data about you and comparing it to all of this other stuff. I really think that that's where it has the most potential is with this ability to get to personalized treatment. Um,
Yeah.
and
And it does that faster. Sorry, go ahead.
no, go ahead.
Yeah, I was just saying that it is something I'm very excited about. It's like it does that much faster than the human eye, and so it's there to augment the human eye. It's not there to replace the human eye.
Yes, and I think that's there's a couple of concerns that, I wanna talk about with AI, and one of them is, this idea that it really can't replace people yet, and hopefully that won't be part of it, but, other areas where breast cancer has just a huge amount of data, where I think we're gonna see some opportunities are in drug discovery,
Yeah.
and also in prognosis and monitoring, whether it's, finding those people who are really high risk to making sure they're the ones that we're keeping an eye on, um, or also, like, monitoring the disease. But most of these are not what patients are seeing outside of the research side, although you might be able to tell me more, because I know this is your field, but, mostly what patients are seeing right now, what we're hearing from them is about breast cancer, screenings.
Yeah, yeah. No, I think you nailed an important point. Is like how can we detect cancer earlier rather than detecting it in the metastatic setting? And this is something I believe in very strongly. I think we are doing okay job when it comes to cancer treatment. Okay, we're not there yet. I know we achieved a lot, but we're not there yet. Yeah, exactly. I look at research right now. We have a drug that doesn't work, and then we have another drug that doesn't work, and sometimes we combine them together, and we hope that those two drugs together are going to do something better. But that's not in the case of breast cancer. Breast cancer have like tons of drugs. I'm talking about
Too
cancer
many
in
options,
general.
right?
Too many drugs. Exactly, too many drugs. But one of the important things is like prevention and detecting that disease early, because we're doing poor in prevention, in my opinion. But I think if we do really good in prevention, we could really, really change the statistics of breast cancer. So I think thank you for pointing into that. And then the other point I wanted to grab your opinion quickly. What do you think about when like do you see patients opening like the currently available AI tools and like asking them questions about their treatment, asking questions about like, oh, what does it mean if my cancer doctor told me like I have a stage 4 or a stage 3? Do you see the patients having that one-to-one interaction instead of Googling, they are AIing or ChatGPTing? Is that a thing or not yet there?
I don't think it's quite there yet for breast cancer patients, but I think it's
Mm,
there for caregivers. So I think, family members are trying to figure it out. They're absolutely doing that. It's getting more and more traction. But if you think about who our biggest group of people who are diagnosed with breast cancer, they're still going to be in that older um, group, right? And that aren't maybe as taking that up quite as much. But you also, when you Google something, you now get that AI blurb at the top, right? So that's,
yeah,
I think,
yeah.
also going to fuel that as well, which is going to be fascinating. We spend a lot of time and energy making sure that we have evidence based resources on our website so that we know that we're getting accurate information because patients like to listen to other patients,
I agree.
whether
I
they're
agree.
their neighbor down the street or the post on Facebook. We see a lot of challenges with people taking things at face value that we need them to actually look at the evidence and go forward that way. So we have invested heavily in this encyclopedic effort about breast cancer on our website or about breast cancer site. More than 180 updates in the last year alone to keep it accurate and up to date. Wow. Harvard. So it's really incredible information. So what happens as AI sort of um, is able to use that and give better tailored answers rather than trying to find it yourself, right? So I think there's a lot of opportunity there.
Gotcha. Gotcha. And can you, we were talking about the challenges. So, like, where do you think the challenges are when it comes to AI going through all this? Because I think also drug development, it's a big thing. And even like using it, I know that there are some centers who are using AI. But like, where do you see the challenges? Is it like regulations? Is it the government? Is it the cost? Is it the adoption by the healthcare provider? Where do you see the challenges mainly in adopting AI more in healthcare?
Yeah, there are so many challenges. I mean, anytime you try to do something big, there's going to be bumps along the road, right? So you hit a bunch of them. I think first and foremost, from a patient perspective, there needs to be this really clear clinical validation with these really large scale data sets that you can say with confidence, yes, this is what it will do for you. What I see happening and what people ask me about is there's a lot of conflicting data and some of it is, oh, well, it improves it in this setting, but not in this setting. Oh, it works for this radiologist, but not in this. Oh, it improves time, but not this. So it's like very hard to like there's no consensus that's easily conveyed to the patients because we're still in those early stages of research where we're finding out all the nuts and bolts about it. Um, so especially as some of these bigger radiology groups are investing in AI, right? And they're offering it to patients at an
Yeah.
additional, but the additional cost always worries us because that, um, one, cost is a barrier. We know that. And two, it adds a little bit to the decision fatigue where you're like, I don't know. Should I get it? Should I not? I don't know. And so then you put it off because you need to talk to somebody before you schedule your mammogram and figure out if you need to do AI. You're going to talk to your nephew or something. I don't know. Um, so that's another issue. Um,
Yeah. Yeah.
the other I other issues are, AI is a great idea in theory and great in research, but implementing it into the real world, so not just a academic research hospital, but into, our small clinics, our, you know, across the world has huge potential for bringing resources there. But at the same time, I'll give you the example of launching electronic health records, right? Um, that was great in theory, right? And it still is.
Oh my God. It's like, it's the worst thing ever. Anyways, I'm going to keep my mouth shut.
I mean, the idea was great, right? Like to be able to align, but the implementation did not go as smoothly as the theory, right? Um,
Yeah. Yeah. It's just like, it led to this pile of data that we don't know what to do and unorganized data, which
oh,
sucks literally.
yeah. Um, you have one hospital that's up to date, and they're using all this stuff. You have other hospitals who use wide open, enter your data. Um, it, it's a real challenge, right? So the theory was great. I think that AI is going to see a little bit of this, where the theory is great, but it's going to take a long time for it to kind of line up and actually be useful in real life. And we also, of course, have to figure out if, based off that, is it actually going to save time, and um, are people going to be willing to use the recommendations that are coming out of it? Um, Another concern is the robustness of the AI model, right? So, like I said, we're seeing lots of data coming out
Yeah.
on a frequent basis. Sometimes it's really consistent. Sometimes it can even be used on the data set it was trained on and still come up with different results. Um, that kind of worries me a little bit. So I think it's going to get there. I know there's just some incredibly smart people working on this, and it's going to get there. But these are concerns that need to be addressed, especially from a patient perspective. If you are trying to explain it to them, and you're like, you can't get me the same answer every time. That would worry me.
I completely agree. And do you think that patients are worried about their privacy when it comes to AI? How do you see it from your end?
Yeah, 100%. Um, so there's actually a study done by Dr. Carter. She talked about what she really confirmed what we know as a patient advocacy organization, that women commonly respond, yes, I'm open to the development of AI in breast cancer screening, but on conditions. So they like the idea that there will be that we're going to use AI to get better accuracy, better accessibility of services as a solution to workforce shortages. But they're really reassured by having radiologists, having an actual doctor look at their films, right? It's a real challenge when you tell them it's just going to be read by a computer. Then they think, oh, it's a cost cutting measure. Why don't I deserve the doctor? You know what I mean? Like, even if you tell them it's better, they
I
don't believe you.
completely agree with that. I completely agree with that. Yes.
So they really aren't fully convinced on that. And then they want to know who else is going to see it. If it's just living in this cache of data, what does that mean? And who can get access to it? Because now it's just sitting in a big pile of data, which means it's available to many people, right? So,
Yeah. Yeah.
rather than feeling like it's a personal connection with just a one-on-one, like I went in, got a screen, my doctor saw me, and it's done. That
Yeah.
feels like a closed loop. Even if the data is exactly the same, like it's living in the same places, it doesn't feel like a closed loop to them. It feels very open. Um,
Yeah.
so
I
one
just want to add one point there.
oh, yeah.
Sorry to cut you there, but because like I think the idea is very fresh, and I want to talk about it. Like you see these headlines, shiny headlines on big news channels. AI will replace doctor. AI this scores 95% on the United States medical licensing exam, or AI that scores this percentage on this licensing exams. But they are not thinking like the problem is like do you gains people how do you gain people's trust? That's a huge thing. Like when you go to a doctor, you're looking for empathy, and then people come and write an article saying that AI's answers are more empathic based on text generation. But empathy is when you look at another human being and you talk to them and you see that they really feel what you're going through. So there is the empathy perspective, there is the trust in computer perspective. I think those things like make physicians irreplaceable at least the next 50 to 100 years, until like we need generational change in the mindset of who is the doctor, who is the person who treats you, before saying that AI can replace doctors. And like the accuracy, that's another thing to talk about. But I think like empathy and the trusting that machine is going to do the right thing for you, it's something that I see patients will need so much time to grasp that. It's not something that intuitive, and patients are not going to do that in the next coming 50 years for sure.
No, it's kind of fascinating to watch. Like I said, we have a bad cancer gene, so we spend a lot of time with doctors, and it's really interesting to watch my family, the range of reactions to doctors, right? So you have people like me who went and got their PhD in cancer research because I wanted to know as much as I could. And then I have other family members who they don't want to know anything about it. They want to pretend like it's not happening, right? So you have this range of people that you need to address and bring along to make good decisions. And I'm really glad you said, you talked about what does it take to get there, because they held this focus group and they really talked about how could they get to trust. And so they gave three suggestions.
Yeah.
One was that they really wanted transparency about the role of AI and its performance, both the benefits and the risks, right? And right now it's non-transparent. Because it's
Yeah.
not related, it's basically a commercial. It's you get a thing that says, "Hey, AI will find more cancers. Do you want to use it or not?" For
Exactly. Like, how does it work? Where is the black box in this? Like,
yeah,
what?
like
How?
and your doctor's not good enough? I think the doctor's good enough. I've been going to him for, this many years. Like yeah, like so I think that's a real issue, is that transparency. And that's an issue with AS, another with AI. That's another concern, because a lot of these algorithms are sort of a black box, right? Like we don't really know what they're finding. We don't really know how they work, or their proprietary information, so it's not really shared.
Yeah.
And you don't know what the difference is. It's only as good as the data it's trained on, and many of them are only trained on one big set of data. They're not multi-center yet. I think that's starting to really happen, and maybe you can tell me more about that. But I think that's a big issue, is what populations the AI is actually trained on as well.
Yeah.
Um,
Yeah. I agree with that point. I just want to add, like when it comes to like the commercially available tools, like right now they are t- trained on most of the available data on the internet, which include PubMed. Like we do have good research data there, but when it comes like when it comes to diagnosing like breast cancer or mammography, like when it comes to this, like I don't think that the data available on the internet it's enough to train these models to do this specific task. And also like beyond that, it's the patients, like for example, a patient from the US wants or expects a different reaction from the doctor versus a patient, let's say in Africa, or a patient Middle East. The AI tools, I don't think they are there to notice these cultural differences between patients and respond to them in a way that makes the patient feel okay, so I can trust, or I can, or I having that empathy, it's not there yet.
100%. So another suggestion that came from this focus group was to use a slow and staged approach to implementation, um, giving time to demonstrate that it's trustworthy, giving people time to get used to it. So not just like, because it's going really fast. All of a sudden, right now it's still optional, right? But
Yeah.
when is it not? And then you're like, well, do I get screened or not? I don't like AI. Then you have to spend time trying to find a way around it. And that's the last suggestion, was that consider an opt-out option. So if people aren't comfortable,
Yeah.
give them the choice to still have um that they don't have to use AI if they're not comfortable. Another group made a really interesting argument that, okay, so with the data privacy, going back to what you said there, if people opt out, because a lot of people are getting more nervous about sharing their data, we absolutely see this. We move forward with our breast cancer registry. People are just more cautious than they used to be, and understandable, right? Data is a powerful motivator, and it's definitely something that to protect, and it's not always possible to do that in
Yeah.
setting unless you're really careful. So one, they're going to have to do more there. But they said that it's going to introduce even more inequities, because people will opt out of AI. And if it is better,
Right.
then they will not have. Plus, AI won't be learning from them and their data. So now, then, especially if you have groups that are very suspicious, don't want to do it, then you're going to start seeing more and more of that bias
Yeah.
introduced.
No,
So
that's very good point. That's very, very good point.
I thought that was fascinating.
Yeah.
So those are some of from the patient perspective, like that concern of, to your point, like having the personal connection. We spend a lot of time trying to convince people. The most important thing to do right now is we need to get
Mhm.
people screened. Um,
Yes.
Screening rates are slowing. No matter if you're getting read by AI or not, it doesn't. The most important thing to do is get screened. And we see a lot of our public health, community health work. It involves
Mhm.
being on the ground, looking at people in the eye, and helping walk them through it, right? So, um, AI is not gonna solve that, to your point. Like, it's not gonna be encouraging people that look good and good, and that they can trust the system. It's going to build up more barriers, as they're more disconnected from the system that's already challenging.
I want to ask your opinion about where do we see insurance in this? Like, do you see insurance is the insurance companies in general? And I don't know if you had that experience from your end. Like, are they pushing toward more AI adoption, or are they against, or are like, and they just don't care?
Um, I mean, I think it comes down to dollars has been my impression, right? So, currently there's no real reimbursement for AI reading. There even, computer aided detection, which is like the step before AI, there's no reimbursement that's separate for screening. Um, there's and this is especially important in radiology, right? So you have,
Yeah.
uh, you get 2 bills unless they're smart and they combine them, but you have the fee to for the radiologist to read it, right? So that's the physician fee, but you also have a
Oh, I didn't know that.
right?
Okay.
So, because radiology has such a high cost in their facilities to pay for MRI machines, CT machines, et cetera. So there will be facility fee and a physician fee. Um, there's not really a place for under the facility fee. It could be under software, but that's really not going to cover the costs because they can't add to it that much, if that makes sense. So in the facility fee, that's not going to quite cover it. And the physician fee gets really interesting because really that's what it should be because it's fee for service, right?
Yeah,
So,
yeah, that's something I don't think you can change much.
well, the only place where you can, add in a
Yeah.
cost, if it assists the physician to do something, right?
Oh,
Well, so that kinda works for some of this stuff, right? You can add in a little bit there, but it also ends up because of the way budgets are and the agreements and different things, I think what it's gonna happen is they're gonna if they put money towards the AI cost, they're gonna
mm,
take it from somewhere else. So it's gonna end up being
yeah,
problematic and not really covering overall the cost of AI. So there's not a good it's a very complex balancing act right now that I think as they move more towards the fee for value, not fee for service, if that makes sense. I think we'll
yeah.
get there.
No, it does make.
AIs will, uh, you can be more efficient. You'll be able to read, you know what I mean? Like, I think that will open up space. Right now, they're just doing it. They're adding it on as an additional cost because they don't have a way to recoup it through um, reimbursement, right? Um, so that's going to be a challenge. And to be fair, like it's still a little bit of the wild wild west with all these different options out there without this really clear data standard. So I don't know that we're going to get to reimbursement rates until there's a little bit more regulation around it.
Yeah,
Um, so direct reimbursement, it's very limited, and payers and healthcare systems are only going to pay for it if they augment the work of the physician. Um, which is if they're going to replace the physician, that's not going to work. So anyway, I think the calls for regulation are going to be really important. There's a couple of groups that are working on this right now. The what are they called? The Coalition for Health AI is working to build the consensus-driven framework. I think that they need some, so the FDA, right? The FDA
mm-hmm,
process.
mm-hmm, mm-hmm.
So I don't know if you know this, but there are nearly 600 devices that are approved right now in
Yeah,
AI.
yeah, they use this AI. Yeah,
Crazy, right? That use AI. But the process, most of them they're approved through the software device, not through the like what you think of as a
software as a medical device pathway. Yeah,
software medical device, right? So it's a little bit different than like a full, drug trial and proposal and all of that.
yeah.
So you have these 600.
There are no randomized clinical trials in them.
Yeah. So, but the burden of data and proof is just it's lower, right? Because the idea was that you get it out there, you can try it, different things. I think they're going to have to figure a way to become more rigorous in order to bring those things together and really, in order to get to reimbursement, they're not going to be able to do it
Yeah,
with the way that they have it right now. Uh,
sure.
and we think that AI should really focus on the benefits to patients and ensure that patients have access. Which is gonna be a huge hurdle to overcome too.
Yeah, yeah,
Right now, the benefit is not on what's good for the patient, right? It's just on what, um, the overall benefit of the patient, right? So
yeah,
we're not like, the endpoint is just straight up, did you find a cancer or not? It's not,
yeah.
did
Exactly.
improve overall outcomes? Does
Did
this
improve survival? Did we detect cancer earlier? Did we improve progression-free survival, or all these metrics that we care about as oncologists as well?
exactly? And that
Yeah,
we haven't shown. The With the AI, it's really just been, did they find something or not, right?
yeah,
False positive, that's a great one too, but it doesn't get us to the full patient journey.
exactly. I wanna ask you, for the sake of time, I wanna ask you, like, let's imagine, and you have all the money and all the power to change the breast cancer screening in the US, and you have the ability to add AI. What are the areas that you would spend most money and most time on when it comes to breast cancer screening?
Um, so again, first and foremost, I would get as many people as possible into screening because I think that's the most important thing. I would implement AI in areas where I knew it had better support structure. So, like maybe in
Mhm.
all the academic centers, and then work towards getting it out further. Um,
Yeah.
Radiologists, there are not that many. There's a shortage these days of radiologists. So
Yeah.
that could be really, really helpful. Especially, I grew up in a very rural area, um, and a lot of these hospitals they close.
Yeah.
Uh, or I mean, back in the day, radiologists had to travel to all these little clinics. Now it's amazing because they can just send the images.
Teleradiology, yeah.
It's amazing, right? Um, but we haven't solved the problem yet, even with all of these advances. So I think AI is gonna tremendously help. I think it's gonna eventually get to the point where it is assisting, and we're getting to the better uh, data that radiologists and oncologists can use. But I don't think it's gonna solve all of our problems. It's not, the magic bullet that we hope for. But um, I think the most important thing is getting more people into screening. That's what I'll tell you every time.
Yeah, I completely agree with you. I think we don't do a really good job when it comes to cancer screening, breast cancer screening specifically, but in general, when it comes to all cancer screening, we're not there yet. No. Yeah. Thank you so much for being here today. I really, really appreciate your time, and I don't want to take more of your time during the holiday season, but thank you so much for being here and sharing your wisdom on our channel. Thank you so much.
Thank you so much for having me. It's great to talk to you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.